but you can't reject clinical studies, especially when you have such an ample amount of observational and, just this wealth of clinical knowledge in the medical literature that tells you pretty conclusively that this works. And if he's rejecting it and he's over exaggerating the harms, quote unquote, the quote unquote risks of the drugs, and then at the same time, it appears as if he's trying to mitigate its efficacy. The hair chemist even erroneously attempts to say that doctors will agree with him. And to complete the ethos of his argument, he refers to Dr. Paresis, who he is also, co-hosting on with this particular podcast.
Finasteride, or the last resort dutasteride, continues to lose their hair. Ask any doctor. I'm sure you've seen the same thing, and you'll agree.
For sure.
And Dr. Paresis, this guy's a hair transplant doctor who essentially parrots the same thing that the hair chemist is saying himself. First of all, there's already clinical data and a full body of medical literature that shows how finasteride, and even better, dutasteride, can slow down hair loss in people that have androgenetic alopecia. I know, I sound like I'm repeating myself over and over again because I want to get to the point. I want you guys to understand this, and more so, I want you guys to see how maybe, I don't want to say dishonest, maybe he could be being dishonest, right? But how the hair chemist is trying to misrepresent things, right? So I keep clarifying people who have androgenetic alopecia, not to sound annoying, but rather to note that if you're losing your hair on something like finasteride, and especially if you're losing your hair still on something like dutasteride, the chances of you just having androgenetic alopecia and nothing autoimmune like a non-scarring alopecia condition like alopecia areata, or even worse yet, an autoimmune scarring condition like lichen planipilaris and its variants, it becomes higher. And if you haven't been listening already, I need you guys to listen right now because I'm going to be exposing something that shows a huge gap and a huge bias that exists in the medical literature, but not in the way that you think. And this could potentially be affecting you. So let's start from the top. Finasteride and dutasteride reduce scalp DHT to a significant extent to the point where the interactions between DHT and the androgen receptors of the hair follicle are greatly reduced. Olson et al. 2006 shows us that between 0.5 mg to 2.5 mg reduces scalp DHT by 50 to up to 80% respectively. Other studies showed that dutasteride wipes out intrafollicular DHT by over 98%. It is possible for someone to be very, very, very sensitive to DHT, such that any residual amounts, however small it is in their scalp, could potentially make them bald. However, I think it's also equally as likely, if not more likely, that if you're losing hair on something like dutasteride, you should probably go get a scalp biopsy in order to rule out that you don't have an autoimmune hair loss condition or any other conditions that could be making your androgenetic alopecia worse. And this is why it's probably better to start out with dutasteride and get a scalp biopsy at the moment of hair loss in order to not waste time in the event finasteride doesn't work for you, because you may be a bit more sensitive to DHT, but also to establish that you don't have an autoimmune, fungal, or inflammatory condition of the scalp that could also cause hair loss too. You see, the issue with many studies concerning androgenetic alopecia and even autoimmune conditions is that sometimes with androgenetic alopecia studies, the subjects are usually not biopsy confirmed to have the condition. And sure, there are a lot of assessments that a doctor can make in the initial assessment of somebody's scalp, right? Androgenetic alopecia tends to take on certain patterns, and you can look at family history. You can look at the scalp to have an understanding by using a dermoscope. And you could, to some extent, say that a certain person has androgenetic alopecia. But a biopsy is a pretty conclusive way of establishing that there are no underlying conditions that may not be visible to the naked eye. And many of these studies just simply don't have a biopsy confirmation that the patient only has androgenetic alopecia and nothing else. Biopsy confirmation requires that a small portion of the scalp, very, very small, maybe 4 millimeters, is cut out and assessed in a laboratory to see if the scalp tissue has any signs of a particular condition. it is important to establish that those who may be getting worse while on finasteride and dutasteride are not getting worse because of some autoimmune condition or inflammatory issue. Because if that's the case, then simply using finasteride or hell, even dutasteride, will not help because it's only going to reduce DHT in the scalp, and DHT is mostly relevant to androgenetic alopecia. According to Kania-Lepe et al. From the Stats Pearl article on lichen planipilaris called lichen planipilaris, cicatricial or scarring alopecia rates are not precisely known, but lichen planipilaris is reported as the most common primary scarring alopecia. But we have a major issue due to some odd industry standards that I wish hair chemists and even Dr. Paresis would rather focus on instead of fear-mongering about dutasteride safety. Kania-Lepe et al.'s literature review on lichen planipilaris points to a major bias that exists in the dermatology space, and this is the idea that autoimmune scarring alopecias like lichen planipilaris mainly impacts women aged 40 to 60. You need to ask a question here. Is lichen planipilaris really more common in postmenopausal women, or is there a bias in biopsy practices? You see, when a balding man walks into a clinic, it's often assumed that he has the typical androgenetic alopecia. For my observations, dermatologists might prescribe finasteride or dutasteride, recommend platelet-rich plasma or PRP treatment, which usually doesn't work, and perhaps order some blood work at the very most. A diagnosis of androgenetic alopecia is given, usually without a biopsy. In contrast, hair loss in women tends to raise alarm among physicians. Even if the hair loss is consistent with androgenetic alopecia, doctors will do more extensive tests to rule out conditions like polycystic ovarian syndrome or menopausal changes. Doctors are more likely to run tests, including biopsies, beyond the initial examination. This is more or less confirmed as a practice. The review titled, quote, Evaluation and Treatment of Male and Female Pattern Hair Loss, unquote, by Elise A. Olson et al., 2005, provides insights into the emerging practices of the early 2000s regarding when to use biopsies for determining the histopathological features of a person presenting with hair loss. The authors state that in men, biopsies are, quote, usually not necessary unless a female pattern of hair loss, diffuse hair loss, or scalp changes suggest of cicatricial alopecia confuse the diagnosis, unquote. This suggests that male patients often bypass the detailed diagnostic step of a biopsy unless their condition deviates from the typical male pattern baldness. In contrast, the review points out that biopsies in women are deemed, quote, sometimes necessary to exclude chronic telogen effluvium, diffuse alopecia areata, or cicatricial hair loss, unquote. So we can see here that this indicates a more cautious approach towards diagnosing hair loss in women. But this is really harmful in the space of hair loss research. This gender disparity in the use of biopsies raises important questions about the potential underdiagnosis of certain hair loss conditions in men. Conditions like lichen planipilaris, which can present in a pattern form similar to androgenetic alopecia norid patterns, might be overlooked. In fact, we have this demonstrated in the literature already. The paper titled, quote, Lichen planipilaris in androgenetic alopecia area, a pitfall for hair transplantations, unquote, mentions how lichen planipilaris can overlap and mimic seborrheic dermatitis. Maybe Dr. Paresis should be concerned here because considering how he's a hair transplant doctor himself, he ought to make sure that his patients don't have this condition, otherwise the hair transplants that he's doing, where he could be potentially transplanting hair follicles into areas that are afflicted with lichen planipilaris, would result in that hair transplant eventually failing. And this could also contribute to the hair transplant failure rate, where even in some people that continue to take finasteride or dutasteride, they may notice that their hair transplant fails over time. And this could also be due to them having a condition other than androgenetic alopecia, like lichen planipilaris, or alopecia areata. I know that Rob English tends to get a lot of bullshit in this area because he used to make some pretty questionable videos back in the day regarding hair loss and essentially overstating how scalp massages can reverse, hair loss. But there was a really, 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 really good video, and we have to give credit to Rob English, where he interviewed one of his clients who had a condition called alopecia areata incognita. So if you guys haven't watched that video, I'll put that video in the description. But it's a fantastic video, but it kind of shows the point that I'm trying to make here, right? Maybe if you're not responding to finasteride, dutasteride, oral minoxidil, topical minoxidil, it could be you have another condition besides androgenetic alopecia, right?